Familial hypercholesterolemia is the most common monogenic disorder in humans. Familial hypercholesterolemia is a genetic condition that results from mutation in the genes that control the LDL cholesterol metabolism. The majority of genetically confirmed cases are caused by defects in the LDL receptor gene, in the ApoB gene, and in the PCSK9 genes. In familial hypercholesterolemia, there is marked elevation of LDL cholesterol, resulting in premature atherosclerotic coronary and vascular disease. Familial hypercholesterolemia is common, but it's underdiagnosed. The prevalence of familial hypercholesterolemia, we'll call it FH, is roughly 1 in 300 individuals, and it's more common in the Middle East with a prevalence of 1 in 200 individuals. Roughly 1 out of every 30 patients with coronary disease will have familial hypercholesterolemia. Once the diagnosis of FH is established, the patient is classified as high risk for cardiovascular events, and so aggressive treatment needs to be started, even if the individual is asymptomatic, not just for lipid lowering, but also for elevated blood pressure readings, even less than 140/90. To diagnose familial hypercholesterolemia definitely, we require genetic testing, but unfortunately genetic testing is costly and is not widely accessible. Also, we don't have a single criterion to diagnose familial hypercholesterolemia clinically. We have to rely on a scoring system, which is derived from the Dutch Lipid Clinic Network database, the DLCNS. The Dutch Lipid Clinic Network database considers the LDL levels in addition to physical signs, family history, and a personal history of premature atherosclerotic disease. But this score requires an accurate personal history, a reliable family history, a thorough examination to look for arcus cornealis or tendon xanthomas, and it also gives different weights for different LDL cholesterol levels. That's why this score is difficult to calculate and apply in clinical practice. Unless the score is definitive, more than 8 points, patients are ideally referred for genetic testing to confirm the diagnosis. But there is some good news. Now we do not need to do any math. As cardiologists, we don't love the math, and we don't love calculations. We prefer simple criteria. Now we have a simple criterion for familial hypercholesterolemia.
Welcome to Cardio Buzz, your one-stop shop for all things cardiology. We bring you the news, groundbreaking research, and the most recent guidelines. We interview the experts in the field and try to answer the most difficult questions of everyday practice.
Researchers from Austria retrospectively analyzed 469 patients who underwent genetic testing for FH in 2 Austrian lipid clinics. The researchers collected the genetic test results, the Dutch Lipid Clinic score, and the LDL levels both on treatment and off treatment. They tested the performance of the Dutch Lipid Clinic Network score compared to a single off-treatment LDL value exceeding 190 mg per deciliter. They compared the performance of the Dutch lipid score and that single LDL value in identifying individuals with genetically confirmed familial hypercholesterolemia. They discovered severe limitations in the Dutch Lipid Clinic Network score criteria. The score, even in a specialized lipid clinic in Austria, was performed in only 48% of the patient's records. They found that 3 out of 8 criteria were missing in the records. This highlights the practical difficulty of obtaining all necessary information in a clinical setting. Moreover, 62% of the scores were inconsistent, suggesting subjectivity and unreliability in applying the DLCNS in a real-world practice. Also, the DLCNS did not outperform off-treatment LDL cholesterol alone. A single cutoff value of 190 mg per deciliter LDL cholesterol compared to the Dutch Lipid Clinical score showed excellent sensitivity and acceptable specificity. Using a single LDL cholesterol cutoff would identify more true cases of FH, but at a cost of more false positive results. Off-treatment LDL cholesterol alone performed well compared to the Dutch Lipid Clinical score in clinical routine as a decision tool for suspecting and testing for FH. The authors suggest using a single off-treatment LDL cutoff of 190 mg per deciliter for enhanced index case identification and referral to specialist clinics for genetic testing instead of the complex Dutch Lipid Clinic score. Of course, we need to understand the limitations of the study. It was a retrospective study conducted in a specialized lipid clinic setting, which may limit the generalizability of the findings. The researchers also investigated a pre-selected population which routinely had genetic testing due to the clinical judgment of the treating physicians and the reasonable suspicion of familial hypercholesterolemia. We also need further studies to evaluate the impact of this simplified screening approach based only on LDL levels on familial hypercholesterolemia diagnosis rates and cardiovascular outcomes. So, we could soon say farewell to the Dutch Lipid Clinic Network score. If you never used it in the past, then no regrets. No need to rely on a complex scoring system like the DLCNS for FH screening. A simpler approach based on off-treatment LDL levels may be more practical and effective in identifying individuals who need further investigation.
Thank you for watching this episode. Tell us in your comments, did you previously use the Dutch Lipid Clinic score to diagnose FH? What's your opinion on using an LDL value of 190 as a sole diagnostic criterion? And tell us, how do you handle those patients with familial hypercholesterolemia and severe atherosclerosis? Don't forget to hit the like button, subscribe, and share the episode with your colleagues. See you in the next episode.